Hey there, Wildcats. All right, let's do lecture two, beliefs, values, and health, how those all fit together. So first we got to ask ourselves, what is health? And your book is totally right to say that a medical model of health really dominates the U.S. historically. Health has been defined as freedom from disease and illness, and then basically because health is freedom from disease and illness, then health care treats disease and illness. So we've got to ask, well, what is disease and illness? And so you could think of illness as identified by a person's perception and evaluation of how he or she is feeling. So if you feel ill, if you have well, let's define what we mean by ill. So we're saying a diminished capacity to perform. And I'm going to come back to this idea of capabilities a bunch in this lecture. And I really want you to pay attention to that idea because I'm going to substitute this idea of capabilities and freedom for the discussion of justice that the textbook does that I really dislike and feel is a steaming pile of garbage, frankly. So we're going to go with a different version of justice, and it's built around this idea of capabilities. So when you feel like you can't perform the tasks and roles that are expected of you by society and frankly that you want to accomplish, then you are ill, right? And so this is an internal kind of subjective evaluation. You're ill because you say you're ill. Now, an alternative perspective is disease. And so we're going to work with this idea of illness as being an internal subjective evaluation, whereas disease is more of a external social evaluation, and it is in fact based on a professional evaluation. So it can be caused by a variety of factors. It could come about as a result of having an actual disease such as tuberculosis. It can also come about from the combination of factors such as living in poverty and having a biological disease. It's an external subjective evaluation because you have a disease if a social authority says you have a disease. So you don't have a disease unless the doctor says you have a disease. It's kind of an interesting way to think about it. So we have kind of illness as being an individual's evaluation and disease being a social evaluation. So we have disease states. We can have an acute stage of disease. So this is, you have some sort of severe episodic kind of situation. And I'm using episodic meaning an episode. So you have this thing that can, you can kind of draw lines around it. It can be cured or not cured in which case you die. It may require inpatient care, right? Or, so acute, the idea of acute care, we'll use the word acute care hospitals, for example. So if you're here in Durham, Wentworth Douglas Hospital over there in Dover is our nearest acute care hospital, as opposed to, say, a psychiatric hospital or a rehabilitation hospital. And what are acute disease states? Well, fracture, for example. So you fall and you break your leg. That's an acute disease state. Pneumonia is another, is a medical disease state as opposed to an orthopedic one. And so you have the acute, severe situation. Subacute basically is just less severe, but it can also be post-acute. And I'm going to use that phrase a fair amount, especially when we get to talking about long-term care. So, so nursing homes used to be basically places where we warehoused old people. And they went and they were primarily residential, custodial residential kind of arrangements. today nursing homes are 50-50, maybe even more, leaning towards rehabilitation. And so you can imagine having well, you can get subacute care at a nursing home. You can also get subacute care in the outpatient setting, so going to see your doctor, right? So it's more about being lower than acute care. And then you have chronic illness, chronic disease, I should say, chronic disease, which is something that is not episodic, right? It is not going to be treated and go away. It's usually not reversible when we're talking about chronic disease, chronic illness. It is not usually reversible. So we think of HIV, AIDS, diabetes. These are diseases and disease states that once you get into them, you manage them, but you can't ever not have them, at least not yet. So hopefully we'll have cures for both of those in your lifetime. So I said that the U.S. has a long history of looking at health from a medical perspective, but the World Health Organization, the WHO, adopted a definition of health as being a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And this was adopted way back in 1946. So this is not like a new idea. This is something from my grandparents' time, your great-great-grandparents' time. Right? So this is a more holistic perspective, and I think it's more broadly accepted today. My father was a physician, retired about 6 years ago now. And, so he did his training in the 70s, and I think there was a much more dominant medical model for his generation of physician. And it was during his career that there was a movement away from the medical model and towards a more holistic, or what we'd call today, a more common word for it is patient-centered care model. So I think the version of health, the definition of health that we're going to work with mostly is this one that looks at a more holistic perspective about the patient. But you should still be aware that there's kind of an old school perspective that that healthcare is a medical-oriented service. Okay, so here's the information I want you to really pay attention to, and I'm going to post these slides. So you should be sure to be comfortable with these ideas. So this work is based on the philosopher and economist Amartya Sen. He's an Indian economist. And he wrote about capability as freedom. So I want to, and this ties into, and I'll come back to this at the end of the lecture, talking about freedom and justice. And he says that our goals are really to, as human beings, are to be doing our doings and beings. So this is a little bit funny language, but I'd like you to try to absorb it. The idea is we pursue functionings, right? So we want to be able to do and be things. So the doings and beings is kind of silly language in my mind. But if you think about it, what is it you want to want in life? Well, you want to be able to do the things you want to do and be the person you want to be. And so, so there's kind of a very basic level of functioning that involves, physical safety, adequate food and shelter, being able to, but then also being able to get married and to the person that you want to be able to get married to be able to pursue an education, to be able to travel and see the world, right? And so in order to achieve a high level of functioning, we need capabilities, right? And capabilities are real or substantive opportunities that allow us to do and be the things we want to be. So a person's capability set denotes the set of capabilities that he or she can choose from. So I think this is not as kind of weird as it first sounds with the functionings and the doings and the beings. It's really, you know, I want a high level of functioning. I want to be able to do the things I want to do, and I want to be able to be the person that I want to be. And in order to do those things and be that person, I need to have capabilities. And so, what do I mean by capabilities? Well, I mean resources, really, right? I need the resources to be able to do and pursue my goals, whether those are things I want to do or things I want or the person I want to be. So you can think of those resources as financial, social, uh, as well as educational, all the things that you bring to bear. So a person who is wealthy from an upper class family is going to have a much larger capability set than someone who's born to a poor, lower socioeconomic status family. So I'm going to use that phrase a fair amount too. So socioeconomic status refers to where you fit in the hierarchy of society. And that could be class, wealth, race, gender, sexual preference, all those things kind of come together, intersect, if you will, to determine where you fit in the socioeconomic status of your society. And it varies from society to society. But a person's capability set tells you what you are or are not going to be able to do. In some cases, even if you had enough money, you wouldn't be allowed to do something, right? So before uh, uh, suffrage for women, even if you were a wealthy woman, you couldn't vote. Um, you know, uh, Jim Crow, if you were African American, you couldn't, even use the same restroom as a white person. So these are examples of social limitations, and I'll come back to this idea, this idea of justice and freedom as justice, and capabilities as freedom, freedom as justice. Um, so the relevance of basic capabilities is not so much necessarily in ranking people, but to say what is the baseline that we need in order to perform basic functioning. And then there's kind of beyond that, then there's a hierarchy. Okay, so I think this is a really interesting thing. I think you ought to hang on to this slide with these definitions. Okay, so we're talking about capabilities. I want to talk about disability, and we're going to relate these ideas back as we go. And bear in mind, I am not covering the entire chapter. There's a lot in the chapter that I'm not going to talk about, but I am hitting some highlights. And so we just talked about capabilities. So I want to talk about disability, kind of the opposite, if you will, of capability. And we use two basic ideas to talk about disability and healthcare. The first one is called activities of daily living, or ADLs. And so if you go into the healthcare field, particularly a couple of you have said you're interested in nursing or other kind of healthcare, you will talk about ADLs. And the other measure, which we'll talk about in the next slide, is called IADLs. So an ADL is basically your ability to function without immediate support, right? And so the basic 7 functions that are measured, and there's kind of a scale of 7 basic functions. If you can eat, bathe, dress, use a toilet, transfer from a bed to a chair, groom, and then walk a distance of 8 feet, right, you have satisfied all your ADLs. So this is commonly used to evaluate the level of care a person requires if they're living in a nursing home or other kind of assisted living scenario. And it is a pretty severe level of, or it's a measure of disability. So if you can't do one of these things, you have a pretty significant disability. Okay, so ADL as opposed to IADL. And the IADL is an instrumental activity of daily living. And it basically asks, what do you need in order to live independently? So you could have some of these challenges from ADLs, but still live independently, right? um, but you might need some sort of physical assistance in order to do it, or technology in order to do these things on your own. So these are higher level functioning than ADLs. If your ADLs are failing, chances are you are going to need to be in an institution, or you are going to require ongoing support around the clock. So IADLs, however, kind of decide whether you can live independently or whether you should be maybe in an assisted living facility or in a nursing home facility. Um, and so assisted living, we'll get to this with when we get to the long-term care unit, but there are different levels um, of long-term care. Assisted living typically means that somebody has some um, difficulties with maybe one of these IADLs, um, but can is generally sort of fairly functional. They just need some basic level of assistance. So that typically, if you're in an assisted living facility, you can, do all these ADLs, but you might need some help. Um, you might have trouble managing your money now. So if you went to the store on your own, a dishonest shop, uh, retail worker might trick you into paying more than you need to do. You might have trouble remembering how to prepare meals or keep track of your medication. That kind of thing is an IADL. So if you can't cook for yourself anymore without potentially endangering yourself or others, then you aren't getting succeeding in your IADLs. Right? Um, so if you can do all these things, then you can pretty much live on your own. But if you have a difficulty with communication or transportation, then you may require some sort of ongoing support. Okay, so we've talked a little bit about capabilities and disabilities. So I want to talk about society and disability. And if you have a disability from the eyes of society, sometimes that evaluation can result in you getting or entitling you to personal social benefits. So Medicare is available to people who have a certain level of disability. Social Security also a certain level of disability. You're entitled to employment accommodations, and preferential hiring. Some often these rely on ADLs and IADLs in the process. Um, I want to talk a little bit about this interesting idea of, so tying back to this idea of illness and disease, where illness is that individual subjective evaluation, and disease is something that society acknowledges. And those two things can overlap. So the idea here is that you have illness here, disease down here, and in this area, they overlap. So you as an individual believe you are ill, you are not capable, and society agrees with you, right? That you are ill. But it's possible for you to feel ill and society not recognize that you are ill. A lot of mental health issues have historically fallen into this kind of zone where there's illness, right? The individual says, there's something wrong with me and I can't perform. And I lack the capabilities to achieve the functioning level that I hope to, that I feel I should be able to achieve. But society does not acknowledge that. Likewise, and I'll show you an example in a moment, there is a society can say there is something wrong with you. You have a disease, but the individual can say, well, there's nothing really wrong with me. I don't feel like there's anything that I need to have done to me. So we can think of the difference between healing and curing, right? Curing is more of a medical um, uh, uh, mindset, right? Of applying something to the body. Um, Healing is something that is working on helping the individual achieve a sense of well-being. Uh, okay, so that's yeah. So I I recently watched the movie The Sound of Metal. It came out. It got nominated for a bunch of Oscars and it won a bunch of awards. And kind of the without giving away the whole plot, because it pretty much rotates around this whole idea. There's a heavy metal drummer who suddenly loses his hearing. And the story is basically dealing with him, or follows him trying to deal with his changed life as a result of this sudden onset of deafness. And what he encounters is a deaf society where where they don't regard deafness as a disability. So going back here, um, it would be this is an example of a situation where society, remember, disease is the social acknowledgement. Society says there is, in fact, something wrong with you. You're deaf, so you have a disease state. But the deaf community, some parts of the deaf community, I should say, do not acknowledge their deafness as illness, and so they don't see themselves as disabled. Um, and so this is kind of a long quote, but kind of summarize a little bit. From a hearing majority, deafness is a disability, but within deaf communities, so you have deaf communities that kind of set themselves apart from the hearing communities, and they have a rich and happy life, and meaningful relationships with other deaf people. And so they don't see themselves as having a disability. And so why should the hearing community treat it as one is the question. So there's a lot to the reason I'm sharing this is, and I think this graphic is really interesting, is sometimes people perceive themselves as ill, as sick, right? And society does not perceive them as sick. Sometimes society perceives you as sick, and sometimes whereas you do not. So another example that's getting a lot of press here is being trans, right? So if you are trans, trans woman, trans man, um, uh, some people in society, some parts of society see you as, what is the right word, gender dysphoric. So there's a kind of technical term that says you have dysphoria, you're confused about what your gender is. But people in the trans community say, no, I know who I am. I'm not sick, right? Whereas, parts of society would say, no, you are in fact sick, right? So that's an example. In my lifetime, being gay was a similar kind of thing. I don't think, generally speaking, we regard, I think there's a general consensus now that being gay is not a illness; it's just an ordinary thing. But um, this really kind of evolved, through the '90s and the early aughts. From a perspective in society that, yep, there's something really wrong with you, to just general acceptance. I think trans is kind of on the way there. And so there's a lot of social stuff that goes on, um, with defining disease or sickness, I should say. So sickness would be the word that would kind of broadly incorporate illness and disease and disability, right? So this idea of disability, is there's a social function there. Okay. Um, so kind of shifting gears a bit, I want to talk about this thing called the epidemiological triangle. And so this is, how does disease come about? Well, there's kind of three interacting factors. There's got to be a host, a person, though I know some of you are interested in, at least one of you is interested in becoming a vet. So maybe a racehorse, but generally for our course, we're going to be focused on humans, but really you could apply this to animals, and maybe even, I don't know, we could stretch it out to like plants. I'm not an epidemiologist. I'm a finance guy. So, but so you have to have a host, somebody who is going to get sick, right? Um, and what are the factors that interact. So we're going to look at the factors. So you have the host, the environment, and the agent, and those three things interact to generate a disease state. And things about the host can influence whether the person becomes sick or not. And so, if you're older, you tend to be more frail. So you are more likely to be uh, harmed by an agent, right? Sex, race. So there's been a lot of discussion about people of color being more uh, um, at risk from COVID. I think, and I haven't followed the science on this, but my guess would be that there's an interaction. So COVID would be a good example. The reason that um, I think the reason that a lot of people of color were more likely to uh, be harmed by COVID was because they also were living they have lower economic resources. And so they're living in more crowded housing. They had jobs that didn't allow them uh, to isolate. They lived in multi-generational households with people coming and going. And so they were more exposed to COVID, not so much genetic factors, um, but the environmental factors. Um, and COVID's a good example, all right. And you have to have an agent, all right, something that's going to cause that can cause the actual harm. And typically, you need the three things to interact. So if you're young, for example, some of you may have had COVID, and a lot of young people who had COVID got a bad, basically a bad cold, some bad headache, and then they were okay in a couple of days, whereas it killed a couple 100,000 elderly people. So COVID is a good example. If you are wealthy, living in a relatively comfortable environment, you were able to socially distance because, say, you were like me, you were a professor, and basically you just went home and did lectures from your house. That allowed you to protect yourself from COVID. If you were young, that was protective from COVID, right? So even though COVID might be around you, your disease would be moderated by the other factors. And then the flip side of that would be if you're elderly, if you're living in a nursing home where you're not able to protect yourself, then COVID went rampant and roared through the nursing homes in New Hampshire in particular. New Hampshire had one of the highest death rates from COVID um, in the country in nursing homes. Um, the disaster in New York City or in New York State, because Governor Cuomo ordered all of the recovering COVID patients to be sent back to nursing homes, was like throwing gasoline on dry wood. Um, he basically just killed I don't know how many people in New York through that decision. So there is the epidemiological triangle is an argument that there are three kind of primary factors that have to interact and do interact to generate a disease state. Okay. Now, kind of focusing on the host, right? We can talk about, so we've talked about the environment. Yes, there are factors coming in from the environment. Yes, there are always factors in the environment, agents in the environment that would like to kill you. The host, all right, we're going to kind of focus on the host and your behaviors of the host that can increase your risk. So some of the big behavioral risk factors include smoking, still one of the leading causes of or leading risk factors to lead to disease state. Substance abuse brings about all sorts of dangers, both in terms of the behavior you're engaged in. So if you're intoxicated, you are more at risk of accidents. People who are substance abusers tend not to be particularly careful about how they administer their drugs. So you have very high prevalence of the two populations that are most likely to get HIV are gay men who do not use condoms, and intravenous drug users who do not use clean needles. Those are still the two most likely to get uh, HIV. So substance abuse, smoking, substance abuse, lack of physical exercise. Man, I tell you what, physical exercise just interacts in so many positive and protective ways. You know, you got to get out and got to move. You know, for me, I'm turning 51 this month. You know, my wife is great. She gets us up and going pretty much every day to do some sort of exercise. It's so important, especially as you get older. You guys are young right now, and you can, you know, eat 3 pizzas a day and you know, play Mario Kart all day long, and you probably be relatively healthy. But by the time you get into your 30s, it'll catch up with you. High fat diet. So again, the 3 pizzas a day, right? So we've you know, diet is complicated. Lots of bad guidance have come out from the government over the years. You know, when I was younger, it used to be that you were supposed to eat a bunch of carbohydrates, and then they realized, oh, maybe not so much carbohydrates. Couldn't eat eggs. Now you should eat eggs. Blah blah blah. High fat diets pretty consistently been proven to be. Having too much fat in your diet has been pretty consistently proven to be a bad thing. But again, it's a specific kind of fat, right? It is, you know, animal fats in particular tend to be bad for you, though fish fats are good for you. So it's a complicated thing. But diet in general, right, is important. And then improper use of motor vehicles, probably one of the biggest killers of people your age, is you know, death from not motorcycles, but motor vehicles. So car accidents, I think is the #1 killer of people your age. And then unsafe sex, right? So if you're out there having sex, you should, you know, particularly if you have multiple partners, you really need to use a condom, use other mechanisms for protecting yourself, not just from pregnancy, unwanted pregnancy, but from disease. So these are the kind of the big ones that the CDC has identified as being, you know, the big behavioral risk factors in our population. So kind of going back to the you know, to the host, right? So the individual makes these decisions. It's you that makes the decision about whether you're going to smoke, whether you're going to engage in substance abuse, whether you're going to get exercise, what you're going to eat and put in your body, if you're going to drive like a maniac, and if you're going to engage in unsafe sex, right? These are all decisions that you as an individual make. Now, we can also talk about the social determinants of health. So I've alluded to this already. But we're going to talk a lot about this. You're going to see this abbreviated SDOH, the social determinants of health. And so these are kind of 5 big groups of factors that interact to generate health, right? And so these are external to you as an individual for the most part, right? They are the result of where you were born, who you were born as, right? So a lot of them have to do with who your parents were, what community you were born into. So a lot of things that you have no control over. And this is important to understand, that we do have some things we do have control over, some things we don't have control over. So if you were born, you know, in a lower SES community, so a lower socioeconomic status community, so a poor community, maybe a minority community, you would have maybe, you know, if you're inner city New York, you know, you might have low quality public schools, right? And so that kind of sets you up for failure from the get-go, because you're not going to get a good education, which isn't going to create a good job, which means you'll have fewer resources, which means you'll have less money in order to be able to access healthcare. You will probably wind up living in a neighborhood that is dangerous, right? So the built environment is a kind of a cool idea. The built environment refers to the physical infrastructure that we live in. So does your uh, does your neighborhood give you the ability to get outside and walk places, right? Um, uh, uh, do you have access to green spaces? So that's the built environment. What is your built environment like? How much pollution do you have fits into the built environment? Social and community context. So social and community. Do you live in a community that welcomes you and treats you as a human being, or do you live in a community that looks at you as an other? So if you're gay, are you looked at as not belonging? If you are a racial minority, are you looked at as not belonging and not welcome, right? So this, or and it can also be just, I've lived places where nobody, where it wasn't that I was a minority, obviously, but where people just generally weren't friendly. There's a pretty good book now. It's a little dated, called Bowling Alone, and the idea is that people are less engaged with community organizations like churches, clubs, and so you go to work and then you go home and you watch Netflix and you're by yourself. Being alone and isolated is not good for your health. Um, Economic stability. So if you're born in a poor area, you're not going to have as much access to economic opportunities, right? So if there aren't good jobs where you are, then you're not going to be able to get a good job, particularly if you have poor education. So the whole thing kind of intersects and interacts. And so these are the social determinants of health. Now, that said, I introduced this concept called locus of control. It's a common psychological concept that's used in management. So I teach this when I teach management. And the idea is you can have an external locus of control where you believe that your behavior is basically just luck, where things just kind of happen to you. Just lost a job again. All my bosses are jerks. As opposed to and I can't get a good job. Nobody wants to hire me. um, right, so the external locus of control is the individual believes that most of things that happen around them are not their fault, like they can't influence them. On the other end of the spectrum is an internal locus of control, where the individual believes that his or her behavior is guided by your personal decisions and efforts. So if you have a high level internal locus of control, if you're successful, you believe you're successful because you worked hard. If you're a failure, though, here's the flip side. If you are a failure, and a failure from your own perspective, then it's because you did something, not because some social force worked against you. And uh, so on the one hand, having a external locus of control can help protect you when in fact, right, societies and social determinants of health are against you. Um, it can protect you because you say, well, some of these things are just not in my control. I'm not going to, get upset about it. I'm going to, kind of accept it as, it is what it is what the, kind of the saying of the external locus of control person is. It is what it is. It's not my fault. It is what it is. Whereas the internal locus of control person is going to be constantly, um, you know, perceiving and blaming, outcomes or because or blaming themselves for any negative outcomes. So people with high internal locus of control tend to take actions to help themselves. And so people who rise up in organizations tend to have high internal locus of control. But those same people, because you have a high locus of control, when something goes wrong, and maybe it isn't your fault, still blame themselves for it. And so they experience a lot of stress as a result. So it's kind of an interesting kind of back and forth. Like, it isn't just like, I'm not saying you should have an internal locus control over everything. You don't, in fact, control everything. So, there's a kind of unhealthy on both ends of the spectrum. The important thing is to be reasonable and to look at both. So let's talk. I'm kind of hopping around a little bit here, but I want to talk about therapeutic preventions. We're going to move into public health and talk a little bit about public health. And at that intersection is this idea of prevention. And so primary prevention really kind of fits into the public health realm. And these are activities that try to decrease or prevent a problem from developing to begin with. And so a lot of these things are actually fairly internal locus kind of control. Like, these are things that you as the host, potential host, can do to fix. So there are things like, don't smoke, right? And if you do smoke, stop smoking. Don't take illicit medications that you buy from some guy on the street. Wash your hands, wear a mask, these days until you get immunized, right? So primary prevention are the activities to try to stop us from getting sick to begin with. Getting exercise, eating well, all those behavioral things we just talked about. Secondary prevention is the early detection and treatment of disease to block anything that does get started from getting worse, right? From really kind of taking hold. So when you turn 50, you're going to get your first colonoscopy. I just had mine about 6 months ago. So they, you can look up, I'm not going to describe it. Luckily, you're out unconscious for the event, but they found some precancerous growth in my colon that they removed, and said, okay, you've got to come back in 3 years. And then tertiary prevention is, you have a disease, you have a situation, a health condition, and we're going to try to prevent it from getting worse, right? So if you are in a hospital being cared for, we're going to try to turn you so that you don't develop bed sores. If you lay in one position for too long, your skin begins to break down and you get sores in your skin. We're going to monitor your disease progression to try to treat it and keep it from getting worse. All right, so what's public health? Well, the idea of public health is to kind of create an environment where people can be healthy, right? So you're trying to create the environment, right? Public health is very focused on the environment where we are living and operating. And we try to prevent and minimize risk factors. It is really kind of the science and art of preventing disease, prolonging life, and promoting health. So prevention, right, is right at the top, along with promoting health. So prevention, so the 3 stages of prevention: primary, secondary, tertiary. Health promotion, so educating people; health protection. And this is, a lot of things around the environment. And then your book gets into bioterrorism and a bunch of other things too. So let's contrast medicine versus public health. Medicine really focuses kind of on the individual, whereas public health is focused on the population. So whereas medicine is going to give you a drug to treat a condition, public health is going to take fluoride and put it in the water to keep your teeth from rotting out, right? It's going to put chlorine in the water to kill bugs that would have otherwise given you cholera. We'll talk about cholera in the next chapter. That's a good time. So public health, right? Whereas medicine focuses on the biological causes of disease, it focuses on the individual patient. Public health really focuses on population. And what we see now is a emergence of the two. Who we see in public health, we have all of these, the people you typically think of as healthcare workers. public health really kind of subsumes medicine, right? It actually includes all these folks, and then adds on to them. So we have not only that, but we have people that focus on, you have a public health office. I did an interview with one of our public health leaders over in Manchester. His focus, they do things like mosquito trapping to see if there are mosquitoes carrying West Nile virus in our community. So we add on all those sorts of things, as well as looking at, public health also sends out people to inspect restaurants to make sure that they're, trapping rats and keeping and cleaning appropriately, because you might not see just how dirty the kitchen is because you're not going in the kitchen when you're in a restaurant. All right. Environmental health, same idea. Environmental health is part of public health, and really kind of one of the formative parts of public health. Historically, the top killers have been communicable diseases: pneumonia, tuberculosis, diarrhea usually coming from cholera. I told you guys in my introductory spiel that I spent my first career in the military doing healthcare for the military. And one of the things that we learned and trained about in the military was, up until the Korean War, so in 1950, more people died from disease, more soldiers died from disease than died from battle injuries. So if you were a soldier in, Napoleon's regiments, you are more likely to die from diarrhea than you were from being shot. Until the 1950s. The 1920s, we discover the first antibiotics, and so if you had gotten an infection in your leg back in 1910, it was highly likely they were just going to amputate it, because there was nothing they could do to stop the infection from progressing. So be grateful you are born when you were born. And of course, we have new and emerging threats. We've actually done a pretty good job of controlling. They were much worse in the 1900s, and even the post-industrial revolution. There's a whole lot of nastiness that we unleashed in our environment, and we've just done a much, much better job. All right, community health assessment. I'm kind of rolling into the end here, running a little longer than I intended to. Apologize for that. But community health assessment is a process that organizations do, usually led by a public health organization. So last year, a group of my students helped the Community Action Program of Stratford County, CAPS. It's run by an HMP alumni. Do a community health assessment looking at the needs of the community. So CAPS is a public health agency. She worked in conjunction with the hospitals in our community. So Wentworth Douglas, Exeter Hospital, Portsmouth Hospital, all kind of play a role in providing that support, as well as other providers. So hospitals are required. JCO stands for the Joint Commission on Accreditation of Healthcare Organizations. So JCO requires that hospitals do this, especially for not-for-profit hospitals. So kind of zooming back in for a moment, thinking about health status in a community, we think about morbidity, and mortality. Morbidity is how sick is the population. Mortality is the death rate. Now, everybody dies. The question is, how long do you live, right? So longevity is related to mortality, right? And we look at, how old are people on average when they die. And the life expectancy used to be quite low, 35 or 40 years old back in pre-industrial era. But that's mostly because most people died, frankly. Most people died as children, below the age of, I forget, 10, something like that. So if you live to your like your first birthday, you had a pretty good shot of making it. If you lived to like your 10th birthday, you had a pretty good chance of living to be about 60 years old. Most people died in childbirth or, within the first year. In fact, in Hawaii, when I was stationed in Hawaii, um, uh, the first birthday, this was among the native Hawaiian families, the first birthday was a big celebration because you made it through that really dangerous first year. And so they would have really big parties for first birthdays. It's a long tradition. I mean, it doesn't really apply anymore, but it's an old tradition. But the reason they did it was because how dangerous that first year was. Um, so as we evaluate health status, looking at both longevity and life expectancy, and then morbidity, the prevalence of disease in a population. So quality of life is really determined, by how healthy are you, right? You can live to be 100, but if you're 100 and you're living in if you spend the last 40 years in a wheelchair, unable to go to the bathroom by yourself, that's pretty low quality of life. So you want to look at the health of the population. We use morbidity statistics. So we look at the at-risk population, and then we look specifically at incidence. We look at specific subpopulations, right? I'm going to skip that. These are all things you should read about. Yeah, I'm going to skip those. I want to end kind of on, because I'm running up against an hour and I want to be under an hour. So I'm circling back to Amartya Sen's idea of capabilities as freedom, and then I would say freedom as justice. And so your book kind of goes on about this social justice versus market justice. I am a free market economist, was trained as a free market economist. And the market justice stuff that he writes or they write about is just a bunch of nonsense. Nobody who leans more towards market-based healthcare believes any of the stuff that they write about in the book. So instead, what I'm focusing you in on here is this idea of capabilities as freedom as justice. Amartya Sen is actually a pretty progressive left-leaning economist. I'm not a huge fan, but I do like this. And I think this idea of capabilities as freedom fits well with our topics. So again, the idea is the just society helps individuals develop capabilities, or better yet, the just society does not intervene and interfere with individuals pursuing their functioning, pursuing the doings and the beings that people want to pursue, right? So a just society creates conditions that maximize freedom, right? And think about this, it wasn't that long ago that being homosexual was illegal in most states, right? You could actually be persecuted for it. You could go to jail for it. This was not that long ago. A society that allows people, that does not interfere with people pursuing their own preferences for how they want to be and what they want to do, is a just society. So a just society helps people develop their capabilities so that they can pursue what they want to do and be the people they want to be. There is a role for government, a significant role for government, and that is primarily a protective role. And public health plays a significant part in that protective role that prevents individuals from or protects individuals from interference by other individuals, right? So it protects the vulnerable from the harassment of more powerful individuals or groups. But it also protects individuals from environmental threats, right? So, so what we talked about with environmental health, uh, the just society, the just government, helps protect individuals, from other groups, and then protects us from the environment. But it doesn't protect us from ourselves, right? It allows us to be the people we want to be and pursue the doings and the beings. It's kind of a cute phrase, the doings and the beings that we want to pursue. Right? It allows us to pursue the functioning that we want to pursue. It helps us build the capabilities that we need in order to pursue our goals, our individual goals and desires. All right, so that is chapter 2. I'll be back tomorrow with chapter 3, and then we'll have office hours on Thursday.